Hi, my name's Adam Sivitz, and today we're going to be going over the scanning technique for looking at the appendix. Now, for this case, we're going to be going over some normal anatomy, and the important normal anatomy we're going to be looking at is the large bowel, small bowel, psoas muscle, iliac vessels, and then our normal appendix. You'll have to know some of these basic things before you go looking for acute appendicitis.
Hey, before you go all Rambo and start pushing on that right lower quadrant that's already hurting in your patient, please be nice to them. Use some warm gel and give them some pain control with some IV morphine or some intranasal fentanyl. Okay, back to the scan.
When we start our scan, we're going to start just lateral to the umbilicus. The reason why is because if the probe is in the center of the belly, all we're going to see is some small bowel, as we can see here. Small bowel generally has fluid or gas and is actively peristalsing. We move the probe laterally to try to find our ascending colon.
Okay, so here's a preview of the scanning protocol and what we're going to be doing for the next couple of minutes. As you can see, the reason why we're focusing on this area and having this exact protocol is because we want to identify the colon different from the small bowel and then really isolate the area around the cecum. The idea is to find it, identify it, and then find the appendix coming off of it. The reason why we do this and not just going to where patients localize pain is because kids do a bad job of localizing pain. They rub their bellies like they're the Buddha or something. This way, you are identifying the cecum and you're going to be able to find that appendix. All right, let's keep going.
As we're scanning, we also want to employ some graded compression. This involves some gentle pressure on the probe to get rid of some of our overlying small bowel structures, and just enough so that we can see the psoas muscle come into view as it is in the bottom right of the screen.
So we all hate obstructed views, and if we could, we would get rid of all those things that's blocking the view of what we really want to see. So how this applies sonographically is we have soft tissues and bowel fluid and gas in between us and the appendix. We want enough compression where we can actually see the psoas muscle and the iliac vessels come into view. This lets us know that we have adequate compression. In this video, you can see the appendix is there the entire time, but really it's most clearly seen once we smush everything away, see that psoas and vessels, and lo and behold, the appendix is just sitting there. So you can see that now we've reached the most lateral portion of the abdominal cavity, noted by the curvature in the abdominal wall. Here we're going to find large bowel or cecum. We know it's large bowel because it does not actively peristalse. Patients may breathe and it may move, but it's not peristalsing. From here we're going to go caudad and basically follow that lateral margin until it's gone completely. This lets us know that we're not going to be missing a very lateral or retrocecal appendix. All right, we are just about to get to the good part. But before we get there, I have one more important concept to introduce, and this is pattern recognition. When we're looking for the appendix, we're essentially looking for two very distinct patterns. It's really the same patterns that we see with just about anything in the bowel. When we're looking at the structure in the long axis, the appendix is going to look like a tube with some overlapping white and black lines that represents the wall layers. And the lumen, well, there could be lots of stuff in the lumen, but for now, let's just imagine that it's dark and anechoic or hypoechoic. In its long axis, it looks like a tube. When you rotate on it 90 degrees and get it in the short axis, it's going to look like a target. This holds true for whether you're looking at the pylorus, whether you're looking at an intussusception, or when we're looking at the appendix. Keep your eyes peeled. Once you're sure you've seen all of the lateral portion of the large bowel, you want to come across and find the medial portion, all the while looking for that tubular non-compressible structure that is the appendix. Now, the appendix more often comes off the medial side of the cecum. Unfortunately, the appendix doesn't always live at McBurney's point in the right lower quadrant. Anywhere from 30 to 60% of the time, it may be retrocecal, maybe lateral, maybe in the pelvis, maybe abdominal. So it's important that you identify the cecum and carefully examine both that lateral and now the medial portions. And so here's the picture that explains why you have to do such a careful job in identifying the large bowel from the small bowel. The cecum is not a fixed structure. It can basically float anywhere, from as high as the liver edge to all the way down into the pelvis. And I used to joke about it But sometimes, yes, it may actually be in the left lower quadrant. Not only that, but even though the cecum can be anywhere, the appendix can be anywhere. And it may start off on the medial side of the cecum, but then it can curve around the cecum. It can go behind it. It can go in front of the terminal ileum. It can go behind the terminal ileum. So again, we have to be very careful in doing the scanning protocol. Okay, so now we've actually found the appendix. It's sitting right next to the psoas muscle, in between the psoas and the vessels. It has a little bit of air in it, so we see that bright white air shadowing within its lumen. We tracked it back to the cecum. Now it's going to drape itself over the iliac vessels, and now we're seeing it in its target form. And take a look at where the probe is in the video in the bottom left corner. We are practically at this patient's umbilicus. In fact, what's sitting directly underneath the appendix at this point is a patient's vertebral body. We are that midline. Now note that when you see the appendix, you can see it both in its long axis, the tubular shape, as well as its target shape. The appendix curves around, and sometimes you can see it in lots of different forms all at once.
It's also important to release compression and make sure that the structure that we're looking at is not small bowel. Small bowel, when you release, will expand without the pressure, whereas the appendix will stay in its regular size. Here we have our target-shaped structure with compression, and as we release, it stays the same size, but now the overlying small bowel is starting to obscure its view.
Okay, so this is a super important concept because this is probably the biggest thing that trips people up. I can take a still picture of almost any structure in the bowel and it'll look round, look like a target, and you may think to yourself, hey, have I found the appendix? Is this appendicitis? It looks kind of big. But releasing some of your graded compression and relaxing a little bit allows that small bowel to reveal itself and expand. This is a way you're not going to let yourself get burnt.
Now again, we're going to employ some graded compression. And we see how well that brings our tubular non-compressible structure back into view. When seeing it in its target form, it should rotate on it 90 degrees and it should become a tube. For novice sonographers, this is much easier using a two-handed technique to rotate the probe and to see your structure going from a target to a tube.
So this is a shout out to all the parents out there. You know how hard it is to get your kids to eat spaghetti and not drop it all on the floor, right? You gotta teach them to twirl it up onto that fork. Well, holding your ultrasound probe, it's exactly the same way. Before you get your carpal tunnel muscles all revved up from doing tons and tons of ultrasound, you're gonna need to hold the probe in one hand and then grab it with the other hand and twist it so that you don't lose the appendix as you're rotating on it.
The last part of the exam involves finding the tip of the appendix. This may be the most difficult part of the exam and should get done in both the long and short views. Without finding the tip of the appendix, we may not be certain that we aren't missing a tip appendicitis.
So that's very important. You have to be able to find that appendix all the way to the blind end, and I'm going to show you in a couple of pictures why that's so critical. But let's start talking about the abnormal appendix. What makes it so abnormal? Well, first of all, it really is non-compressible. A normal appendix, you can actually smush a little bit. It may look a little bit round. If you put a little pressure on it, you can turn it into a flattened oval. But a diseased appendix, all the pressure you want, that's going to stay round. It's going to have a greater than 6 millimeter diameter, and we'll talk about the measurements in a sec. Round, 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 it's got to be round. And periappendiceal inflammation. You cannot have appendicitis without the itis. The itis is the inflammation. There are people out there walking around, minding their own business, that have appendices that are 6, 7, 8 millimeters in diameter, and they don't have appendicitis. You need to have that inflammation. So here we have a picture of the appendix, and forget the tubular non-compressible part. Look at all the grayness that's in our view around this structure. All that whitish, all that gray. For those of you that do subcutaneous abscess evaluations, the same things that we see with those subcutaneous abscesses, all that cobblestoning, you actually see that in the abdomen. That's the inflammation you want to look for. And here we're doing an outer wall to outer wall measurement, 8 millimeters. We've got appendicitis. Now, we talked about being able to follow the appendix from its origin all the way to the tip. So you can see with the green arrow, there's actually a little bit of the proximal appendix on the screen, and it looks oval and it looks normal in diameter. But as we've gotten more distal, it kind of curves around on itself. We're looking at that blind end, and around there, lots of periappendiceal inflammation. The diameter is much wider, and if we rotated on this 90 degrees, this wouldn't be an oval, this would be a circle. Here's another view, looking at it in its cross section. Now, what I want your eyes to look at is the psoas muscle that's underneath the appendix. This appendix is dilated and exerting pressure on the muscle underneath it. Look at how the muscle's almost bowing inwards because we're putting pressure on the appendix with our probe from above and pushing down on that muscle underneath. So we talked about releasing compression, adding compression, able to differentiate the appendix from small bowel. Another must is you got to be able to rotate on that. If you're seeing something that looks like the appendix and it looks like a tube, you got to be able to rotate 90 degrees, and it should look like a target. And here's a great picture of why it's so important to make sure that you can get to the tip of the appendix. This appendix was normal for 90% of its course. And for the last couple of centimeters that we have here, we've got an appendicolith that's blocking up the lumen, and the tip is dilated out to 1.1 centimeters. This is the classic tip appendicitis that unless we had looked its entire length, we would have missed this one. All right, guys, one last important note. You saw a couple of pictures of measuring the appendix from outer wall to outer wall. This is a good measurement. Thumbs up to you. Now, what I don't want to see people doing is doing that graded compression, and if you have a normal appendix, what's going to happen? You're going to be able to smush it down and turn that circle to an oval. And when you do that, that lateral diameter is going to get wider. You're not going to go from a 5.5 millimeter appendix, smush it down and turn it into 6.5 and call that appendicitis. Please don't do this.
All right, guys, you made it. Thanks for watching. Hopefully you learned something from this. Hopefully this has gotten you excited, and the next time you have a patient who comes in with right lower quadrant pain, you're going to bring that probe to the bedside, take a couple of minutes and take a look and see if you can find the appendix. Now, this is not a scan for the novice sonographer. The appendix is not as easy to see as the heart or a liver. It's going to take a lot of practice. It's going to take a little bit of time. But once you start recognizing those patterns and once you start getting good at it, this is going to be another little notch in your belt, another part of your armamentarium that you're going to bring to the bedside. And all those 2, 4, 8-hour workups waiting for labs and consultations and imaging and contrast, those are going to turn into 20-second, 2-minute, 4-minute evaluations with you and the ultrasound at the bedside. So again, thanks for watching. Hope you learned something.
Thanks to Chloe and Sam, who mostly held it together to make this possible.